इसको भी कर देते हैं। फेसबुक लाइव हो गया है?
Yes, we are live now, ma'am.
All the places?
Yes.
I can start my talk?
Yes, yes.
Thank you. So thank you, Team Corona. Corona is known for coming out with the novel idea, and second Monday of every month at 7:30 p.m. we come with one topic and we have nearly 40 minutes on that. If there are any question answers, you will always put it on a whatever the chat box or what they give. Bhumi, किस पे होते हैं question answers? Anyway, Bhumit has disappeared.
Hello.
Probably.
Yes, ma'am.
Where the question answers they have to make?
No, ma'am. We don't have any questions at present.
I think every Monday I do that, but if you don't know, that's okay. So let's start. Today, we will be talking about FGR. What are the recent advances? Friends, advances in science is always for the betterment of human being. What happened in last 3 to 4 decades is the advancement in imaging technology.
Hello. Sir, live ही था और मैम के
Bhumit, will you mute yourself? Our lecture is going on. So what advances has happened in a science in last 3-4 years is first is technology. The way imaging is happening and the way we understand the subject more and more with the better viewing, our understanding of the subject has improved. Addition of the Dopplers have made us to understand the pathophysiology of FGR in better way. We can monitor the babies. We can take the decision of termination in a well appropriate time. Unnecessary delivering too early with the fear of a IUD or delaying and allowing the IUD to happen, both can be avoided by better Doppler sonography studies. So friends, today we will talk about FGR. The clinical updates. This is the what paradigm shift has happened. You are disturbing me too much. Stop it. Let me get connected. I'm not able to, you are doing so much movement around me. Thank you, beta. Thank you. Call it a day. Good for you. Chutti. Thank you. And come tomorrow and start doing. Sorry, dear. FGR, a paradigm shift has happened. We used to small for gestational age fetuses are those fetuses with an estimated weight of less than 10th percentile. So they include both constitutionally small size or pathologically small size. We call it as a FGR. Constitutionally small means there is no maternal pathology. The Doppler's indices are absolutely normal, while in growth-restricted fetuses, small fetuses with a recognizable maternal pathology or an abnormal umbilical or middle cerebral artery Doppler studies. And idiopathic means when we don't find any maternal pathology, we find everything is normal as far as mother is concerned, but there is an abnormal fetal Doppler and there is a FGR. Now, the problems of FGR fetuses, morbidity and mortality in the perinatal period is vastly increased in this. But if you really compare, there will be at a greater risk of stillbirth, birth hypoxia, neonatal complication, impaired neurodevelopmental, and possibly type 2 diabetes or hypertension in adult life. So it is not only we deliver, we need to ensure that the mother or understand that there will be early adulthood problem also. However, whatever we said, vast majority may not have any appreciable morbidity or mortality. So when we talk about pathophysiology, what happens in FGR is a fetus responds to chronic hypoxia in a predictable sequence, and that gets correlated with acidemia from the blood gas. So fetal acidosis or hypoxia, you can have a cascade of these appearances of lead deceleration, disappearance of acceleration, absence of breathing, baby tone may not be. And this chronic hypoxia you can detect, but acute hypoxia sometimes is difficult to detect on a sonography. Now, if we talk about common etiologies of fetal growth restriction, we usually divide into maybe a maternal, maybe a placental origin, maybe fetal origin, or an umbilical origin. It is important to note that there is often confusion between the etiologies and so-called risk factors. For example, the mother have a chronic hypertension, she may be diabetes, she may have a SLE, she may have a kidney diseases. We unnecessarily label them into the maternal etiologies. As such, we should consider them that these are the maternal risk factors which may lead to abnormal placentation or placenta-mediated FGR. Now, maternal means preplacental factors, hypoxia, chronic lung diseases, anemia, smoking substances. Don't do, na? You can wait outside, no problem if you're getting bored. Hypoxia, chronic lung diseases, high altitude, anemia, smoking, malabsorption, poor weight gain, environmental toxin, all that can come into preplacental. Placental factors means maternal vascular malperfusion pathology, infarction, chronic abruption, fetal vascular malperfusion pathology, chronic placental inflammation, velitis, or confined placental mosaicism. Umbilical cord, we can say about increased coiling. I do have one patient today, and antenatally it's going on. There is increased coiling and giving the FGR. So sometimes that itself we are worried because it may give a little bit thromboembolism factor also. Increased cord length, true knot, all that can happen. Though true knot, I will consider more for a sudden problem than a chronic. Fetal disorder. Genetic is the most common cause. Structural abnormalities, congenital heart diseases, congenital infections, or teratogen exposures because of the drugs and the toxins. So one has to understand that FGR is principally not the consequence of a reduced maternal nutrition, but reduced materno-fetal supply of the nutrients, and later the oxygen through the damaged placental vascularity. So it is the perfusion which is a problem. It has been suggested that FGR should be broadly classified based on the gestational age. So instead of talking about the symmetrical FGR or asymmetrical FGR, we call it now as an early onset FGR, that is less than 32 weeks, and late onset FGR, that is after 32 weeks. Now, early versus late onset. Early onset has a prevalence of 0.5 to 1%, usually is more severe and is more likely to be associated with abnormal umbilical artery Doppler. The underlying placental pathology is frequently similar to that observed in cases of early onset preeclampsia, that is maternal vascular malperfusion, which explain the strong association of early onset FGR with preeclampsia. And therefore, early onset FGR is usually easier to detect, and the natural history tends to follow a predictable sequence of Doppler changes. If I know that this patient is having at 12 weeks, maybe a high umbilical artery Doppler in resistance flow, maybe low PAPA, maybe patient has associated PCOS or ART treatment where I think that patient probably may develop PIH. And these low PAPA and Doppler indices are telling me that patient will probably may land up in a FGR. So we start thinking about and we start predicting about it. While late onset is more common than early onset, 5 to 10%, usually it is milder, is less likely to be associated with preeclampsia, and usually it will have a normal Doppler flow. Therefore, the main challenge with regard to late onset is diagnosis. But the management is relatively simple because we are reaching near term. So there is no much tension or no much stress than at 26 weeks to 27 weeks. If I'm finding that the FGR is happening, then I know that another 10 to 12 weeks to carry on this baby may be difficult. But in late onset, because we are near term, the treatment option becomes little more easy. The diagnosis of late FGR mainly relies on adaptive changes in the cerebral circulation because there is a redistribution or a brain sparing effect, which is reflected by low resistance to the flow in the middle cerebral artery, thereby generating a low cerebroplacental ratio. This is very important. So if your sonologist is extremely good, or if your fetal medicine consultant is good, they will pick up this. They will tell you that there is a brain sparing effect, or they will tell you that there is a low resistance to the flow and there is low cerebroplacental ratio, indicating probably this patient might be going into the FGR. Early prediction of a fetal growth restriction. Can we do that? Yes, of course. History taking. That is what I say. Though the word has come inverting the pyramid of antenatal care, they were at 12 weeks. It is the window of opportunity, we say. I always used to believe for last 2.5 decades that we should work like a preventive obstetric. What complications can happen in third trimester, either with the mother or with the baby, can we predict them early? One, by detailed history, maternal advanced age, underweight, malnutrition, living in a high altitude, so hypoxia, severe anemia, or a hemoglobinopathies, environmental factors associated these all maternal condition, as I discussed earlier, previous history of FGR or a PIH, all this is very important. And biochemical markers. I am not going to say that you do for all this AFP and all, but PAPE we are doing in double markers very routinely, and low PAPE should ring the bell. We should inform us that I need to be very careful. And on the top of that, at 12 weeks, if I see the uterine artery pulsatility index above 95 percentile, so we should start working. Can we think about prediction and can we think about prevention? Both are equally important. For example, these patients with low PAPE, with the high pulsatility index, I will go in detail, advanced maternal age. If the ART conception, I may think of this patient very prone for a preeclampsia. I may think of starting echosprin between 14 to 16 weeks. And that's what I'm trying to say, that by 19 weeks, you may think that the Doppler indices may come normal. But all these Doppler indices are very important. Now, prediction module, there is no single screening test. It is how in ectopic pregnancy, we say high suspicion in your mind. And then you closely observe that early pregnancy. Same is here. You need to suspect in your mind which are the patient which can go in a FGR, and can you do little more close monitoring with them? And that monitoring includes everything. Now, risk factor for a HGA. Low level of the first trimester low PAPE, already I've told you, and serial ultrasound measurement. If you see that the fetal size and the Doppler flow are not going corresponding, it's not a single fetal size measurement, but the curve. You have to think that how on the curve line we are going. Sometimes, I know it's a difficult, crowded slide, but a woman who have a major risk factor should be referred for a serial ultrasound measurement for the fetal size and assessment. So if I find any one major factor, I should do little more closer and serial sonographic monitoring, and maybe a Doppler studies from 26 to 28, and three or more minor risk factors. We should be referring this patient for early Doppler studies from 20 to 24 weeks of this, and that is triage, which is very important. Now, prevention. Is it possible to prevent? If we can predict, of course, you can stratify the risk stratification for this FGR, and you find out, is there a preventable or predictable, and can we avoid? Sometimes, yes, you can. For example, she's smoker. Stop smoking with immediate effect. Alcohol, moderate amount or small one too, that's different, but chronic alcoholism may affect. Association of an insufficient weight gain or excessive weight gain. Both are equally damaging to the baby. There are insufficient data to recommend routine treatment of an aspirin to all high risk FGR. There's no point, but those whom you feel that they are the high risk for a preeclampsia or a history of a placental mediated FGR, you can definitely think about starting 150 milligram of a dose. But definitely low molecular weight heparin is not recommended just on a low PAPE or a high pulsality index. You cannot. How to detect the FGR? Confirmation. I also should be mentioned about the immunological factors. Immunological factors, if they are positive, maybe in patients with anticardiolipin antibodies positive, lipase anticoagulant positive, we know that apart from a PIH, they may have oligohydramnios, they may have a FGR, and these are the patient, definitely we put them on a LMWH. How to detect then FGR? Confirmation of the gestational age. Let's not think about only advancing. Let's take your history measurement. The confirmed patient having a very regular cycle, fantastic. And if not, then the first trimester crown rump length is the most accurate method to date the pregnancy when in the range of 7 to 60 millimeter, the fetal crown rump length. And in low resource setting, dating may be done based on the symphysis of fundal height. So confirmation of the gestational age should be our first step when we suspect the FGR. And with the exception of a pregnancy is achieved with the ART and frozen embryo transfer, then we will talk about the first scan. If more than one scan is performed in the first trimester, the earlier scan of at least 10 mm should be used as the main. And the low resource setting, the symphysis of human. How do we do that? So first is your abdominal palpation. You see the abdominal girth. You see the symphysial fundal height. That is very important. And then the patients whom you have felt that clinically she was 24 weeks corresponding. Now when I called her at 28 weeks, I'm finding it 26 weeks. At 30 weeks, I'm finding less. Or even at 20 weeks, I'm finding it is like 16 weeks pregnancy, early IUGR. I will be very much worried about this all. So you can start thinking about it, and then accordingly, the ultrasonography with the specialist who understand your FGR monitoring with your Dopplers are equally important. Now, symphysis of fundal height. Why it is important? I did my graduation in the ages in 86 to 89. This was our routine way of measuring. Empty the patient's bladder, make her lie down, take a tape and do the measurement and write down in her ANC file. It was a simple, inexpensive and widely used strategy to screen, and this is getting forgotten in a private setup. So this should not happen. Serial measurement of this is recommended at each antenatal from 24 weeks, as that improves your prediction of a FGR. Symphysis of fundal height should be plotted on a customized chart rather than a population-based chart, as they may improve the prediction. For that patient, it is important. Woman with the single symphysis of fundal height, which plots below 10th percentile, or serial measurement which demonstrates slow or static growth by crossing the centiles, should be referred for the ultrasound measurement of a fetal site by the experts. Woman in whom it is inaccurate is like high BMI, very obese patient, having associated fibroids, patient having polyhydramnios, then you need to do the serial sonography and you cannot just depend upon your abdominal palpation. FIGO in 2021 has said even your single symphysiofundal height measurement at 32 to 34 weeks of pregnancy is reported to give approximately 65% to 85% sensitivity and 96% specific value. This is very, very important. It is so important. So you cannot say the patient has come for late registration. Still at that age, it is important. And then you sit and work out her retrospective history. So sonographic fetal, I'm sorry, I don't know. This was here. Sonographic fetal weight estimation, standard fetal biometry. It includes the head circumference, biparietal diameter, abdominal circumference, and the femoral length. Femoral fetal weight is estimated based on a various combination of 4 biometric indices described above and using one of the many published equations. You let your fetal medicine consultant decide, and then she gives you. Most studies concluded that equations that are based on 3 or 4 biometric indices provide more consistent than just 1 or 2 indices. And in many countries, especially developing countries, measurement of symphysiofundal height is the primary screening tool. And don't forget that. But this approach may fail to identify many FGR fetuses, a concern finding given that undetected FGR is associated with perinatal. So you cannot just say, I'm going to do per abdominal without sonography. You can't bypass the sonography. Sonography is very, very important, and routine third trimester ultrasound on low risk pregnancy. So usually after 28 weeks, if the serial, my clinical judgment is going well, the fetal height is going well, and I'm finding the overall size of the baby is also very accurate, I may not do the sonography. But if I find that I'm not getting corresponding, I should be taking the help of a sonographic measurement. And uterine Doppler in high-risk population, of course, from 20 to 24 weeks pregnancy, because it has a moderate predictive value for a severe FGR, and woman with the abnormal Doppler at 20 to 24 weeks with the subsequent normalization. So you see, at 20 weeks, there was an abnormal Doppler, but subsequently, the Doppler became normal. But remember that these fetuses are still at increased risk of FGR, and don't think that your echospleen has done a wonder and Doppler studies have come normal. This is a very important point to be noted. Women with the normal uterine Doppler do not require serial measurement of a fetal size and serial assessment of a well-being with umbilical Doppler artery unless they develop specific pregnancy complication, for example, APH or hypertension or something. However, they should be offered a scan for a size and a Doppler during third trimester. I usually do between 28 to 30 weeks, a routine 1 scan at the beginning of third trimester. Optimum method of diagnosis. Change in abdominal circumference or estimated fetal weight may improve the prediction of wasting at the birth and adverse perinatal outcome. When using a 2 measurement, minimum 3 weeks distance you should try and keep to avoid false positive, red, and unnecessary overdiagnosis of a FGR. That is also equally worrying. Now, if my sonologist is saying me, yes, you have it, what shall I start doing investigation? I understood that, okay, at 28 weeks, the growth is going on like 26 weeks, 2 weeks lag behind. 19% of the fetuses with abdominal circumference and estimated weight less than 5th percentile may have a chromosomal defect. So you should go back and see whether we have missed any anomalies in this. Risk is higher when the growth restriction is associated with structural anomalies or normal Likert volume or a normal Doppler. So if there are any structural abnormality which are giving, all FGR fetus need a detailed sonography at 18 to 19 weeks. That is why the habit of doing a Doppler study with is important so that retrospectively we can see. Serological screening, try and see whether you have done this and whether you need to do that. Testing of a syphilis, malaria should also be considered in a high-risk population of that area. Amniocentesis. Now, if it is after 24 weeks, probably it may have just the diagnostic role, but if early, one can think about and one can ask for an early onset FGR if it is going to be at 18 weeks. If you find that it is less than 3 percentile, you know that you are facing a difficult baby, structurally abnormal or not, probably genetically abnormal, and you need to start working on that. Problems with certain tests. You require accurate estimation of the gestation. Yes, that is okay. Most tests attempt to diagnose HGF fetuses rather than growth-restricted fetuses. So small for gestational age and not FGR. Most of the studies which report FGR have no differentiated between constitutionally and pathologically. So if you go and see more in a depth about that study, you will find that they have not differentiated. And most studies use one of the cutoff, either size to predict SGA, while there is evidence that there is a train which is more of value and not one measurement which is of value. In most situations, no allowance is made for the importance of prognostic factor, such as maternal height, weight, ethnicity, parity, fetal gender. All this is important. Of course, gender you cannot see in India, but otherwise you should see all these written things also. And it should also be noted that an individual test may not be predictive. A composite of abnormal result, such as ultrasonographically small fetus with reduced Likert, abnormal Doppler, they probably may help us in a better way. How to assess in a twin gestation? Twin fetus grow more slowly than singleton, starting from 28 to 30 weeks, 32 weeks onward. Till that time, that's okay. But of later, you know that the fetuses will start growing little slower than the singleton. At term, approximately 30 to 50% of the team will be identified as small for gestational age, less than 10 percentile. Some believe that this represents a pathological phenomenon due to the failure of uteroplacental circulation to meet the demand of two fetuses, but others also suggest that this may be a benign physiological adaptation of the twins to the crowded intrauterine atmosphere. And that is where the problem is. Based on the available evidence, it seems reasonable to use twin-specific chart for the assessment of fetal growth. So if at 1.2 kgs, I find these at 28 weeks of gestation, I'm fine. At 32, otherwise, I may get around 1.8 kg, while with twins, I may get 1.5 kgs. Lagging behind, I should not be thinking immediately for a FGR unless I'm worried that they are IVF conceived, elderly age, associated other pathologies like development of a PIH, immunologically positive, where I will say that they are twins, but they are FGR because the growth is less than 5 percentile. So it is very important you check the inter-twin size discordance, especially in a monochorionic placentation. Now, management of pregnancies with growth retardation. So I will start thinking with the history. I will start predicting with my serial checkup of the patient from 12 weeks to 20 weeks to 24 weeks to 28 weeks. I'll start, and I may be intelligent in detecting or in finding the FGR fetuses. I may be able to go to the root cause of it, or sometimes I may be idiopathic. I understand all. But now, how do I manage that pregnancy? They are going like 3 percentile. How do I manage? The primary management challenge arises from the risk of fetal deterioration and stillbirth in a pregnancy undergoing surveillance versus neonatal morbidity and mortality associated with preterm delivery. So the dilemma is she is growing with only 2 percentile and she is 32 to 33 weeks. The dilemma is if I continue and I land up in IUD, or I deliver and I land up in preterm premature plus IUGR, are deadly combinations, whether I'll be able to survive or whether I will have a morbidity in the adulthood diseases. So, in cases of fetal abnormalities, obviously genetic or infectious, management will depend upon individualizing what are the problem you have. The most common underlying etiology still will be a placental dysfunction. An early onset FGR, increased resistance in the Doppler, is the primary rate limiting step to subsequent deterioration of a cardiovascular and biophysical parameters. There is no effective antenatal treatment. Remember one thing, if you found also there is a placental dysfunction, can you just stop it? Can you just avoid it? Just by giving up ecosprin 150 milligram, are you doing a cure? No. We have to understand that. First thing is, even if I start on that, it is going to progressively detect. Only it may help me to certain percentage. It may help me to take the pregnancy little further ahead. But what is most important, especially those who are in a smaller cities, first is ensure that this patient needs little more institutional setup for a fetal surveillance and also appropriate determining when to deliver the patient. I had been to I don't want to label this name of a city because of my Foxy election. I'm moving around. And just last month, I came to know that in their city, they don't have a good sonologist who can understand. And no fetal medicine consultant is ready to come and settle there because it's a small city. No one likes to have their future prospects there. Unfortunately, whether they wish or not, they don't have these facilities where they can do the close monitoring, or they have to learn themselves to do all that, which may be difficult in a busy obstetric practice. Perinatal outcome in an early onset FGR, that's what my suggestion to them was that time, that you all 20-25 obstetrician come together, talk to the fetal medicine consultant who have fellowship program running, and ask them to send one of the fellow at least for 2 years to practice in that city. And together, unanimously, you refer the cases to him. So he also survives. If he likes the city, he may settle. If he doesn't like, he wants to move on. He solved your problem for 2 years. Uske bhi haath ki safai ho gayi. He also did lot many scans. And then the next fellow can come and settle. That is how we all have to help each other, especially in smaller cities. And they should find out nearby. They should explain the patient that, listen, probably you may need a higher level fetal medicine and neonatology unit for antenatal checkup also to decide when to deliver. Forget only for a delivery. In late onset FGR, cardiovascular deterioration in response to hypoxia is predominantly, as I told you, is confined to the cerebral circulation with less of an umbilical artery Doppler and cerebral vasodilatation. Your intelligent fetal medicine consultant will tell you. Likewise, the optimal management setting in a late onset FGR is a unit that has an access for interpretation of the surveillance test together with the appropriate neonatal unit. And that's why lets them have in a tertiary care unit. Optimal method. In a high-risk population, the use of umbilical artery Doppler has shown to reduce the morbidity and mortality quite a lot. Umbilical artery Doppler should be a primary surveillance in a FGR. CTG alone cannot be used. So don't say, I have a CTG monitoring and I'm doing CTG monitoring. Please don't do that. Unless you know how the Doppler flow is going on, it's very difficult just to rely alone on a CTG or a biophysical profile. Now, can I think about, I got at 26 weeks detected. It is not PIH high risk also. I cannot give ecosprin because it's not indicated. She's not fitting into that group. She did not have a low PAPE. What empirical treatment I do? First thing is do no harm. Do not waste too much of money in thinking that you can do something and you can help that to provide the nutrition to the baby. Only thing is certain things, smoking, as I already told you, thinking about antithrombotic in only required classes. Antiplatelet, I have already spoken. The adjuvant therapies I'm talking, there is no enough evidence to assess the value of giving oxygen 3 to 4 times a day. Though I tell all my patients, first is I put them on high protein, low carb. I ensure that they have adequate hydration unless they are prone for PIH, where I may not tell them good hydration or excessive hydration. Third important thing is I tell them go in the gallery in the morning and evening, sit and take a deep breathing. 6 a.m., get up and go in the gallery and sit there. Or if you have a beautiful garden, just go and sit and take a deep inhalation. Oxygen therapy, I'm not saying that you hospitalize and give it half-hourly oxygen, but I definitely feel that oxygen therapy, though evidence doesn't say it, I do that. Nutrients, I take a tremendous care of their diet, which should be balanced, but more of a protein and less of a carb, especially on the patient who have already gained excessive weight during pregnancy or who are prone for a PIH and diabetes. I will not allow much of a high glycemic index food. If they are fond of rice, I tell them, go for a brown rice, which has a low glycemic index over the white rice. If they just want to eat rice, see that they replace it with jawar ki roti. They cannot have 2 rotis and a bowl full of a rice and a heavy calorie diet. Hospitalization and bed rest, I don't think this will help, and how long you will keep a bed rest. Beta mimetics, calcium channel blockers, any other hormonal therapy, plasma volume expansion, calcium, progesterone, all, there is no evidence to prove that it is going to help in treating the growth restriction. But out of these all, I think oxygen therapy, taking care of our nutrition, I tell them 2 to 3 hours in the afternoon and 7 to 8 hours in the night, they should be in left lateral position. They may not get sleep, but they should be in left lateral position. Just keep their mind closed, meditate, or they can talk to baby. Baby, they can talk and they can say, you are not going, but I'm protecting you. I definitely feel that mother has a power to save her own baby. She should be continuously in touch with the baby and she should love the baby beyond herself. Evidence for adjunctive therapies. Most prenatal interventions do not show any significant effects again and again. What about the steroids? Yes, definitely. Steroids should be considered and they should receive the steroid. Betamethasone preferred over dexamethasone. No benefit of repeated steroids. Remember that. It may cause more harm than the help. What about the MgSO4? Yes, as a neuroprotective, you can think about giving when you are trying to deliver before 32 weeks of pregnancy. It should be MgSO4 for all the preterm. For this, 4 gram IV loading dose followed by 1 gram per hour, and you can deliver after 12 to 24 hours of a loading dose. Or you see to it that what is one very important thing with the MgSO4? I feel so that these babies, they don't immediately cry. They are weak, lethargic, because MgSO4 has crossed the placenta with the baby also. So your neonatologist should be all ready, even if necessary, for an intubation of that baby. Timing of a delivery. When should I deliver now? This is very important, and I want you to concentrate on these last 4-5 slides. In case of isolated mild FGR, estimated fetal weight around 3 to 9 percentile, no additional Doppler problems, fluid is going very well, only the baby size is showing a decline. You can continue till 37 to 39 weeks, but just do the monitoring of the baby, maybe 1 to 2 weekly. I will keep on doing weekly sonographies, Doppler studies, and I'll continue. For mild FGR at term, monitoring with CTG and NST or biophysical profile 1-2 times per week may be considered in addition to Doppler. So if the baby is about 36 weeks of pregnancy. In isolated severe FGR, less than 3rd percentile, but no additional abnormalities again. I find Liker is good, Doppler is good, please continue the pregnancy. Ask the patient, as I told you, empirical line is just the talking to the baby, good nutrition, adequate hydration, and good oxygenation in the balcony, and just see to it that you are in a positive mode by yourself. And then you can continue this pregnancy. I tell my patient daily fetal movement count, very, very important. Ideally, even if you get 10 counts in 12 hours is good. So I tell my patient, just have a nice breakfast at 9 o'clock, lie down for half hour and just concentrate on a baby movement. If you got 2 kicks, 3 kicks, 4 kicks, it's beautiful. Patient comes and tells, oh, I got 8 kicks in that half hour because she was concentrating. She is measuring even the smaller kicks. That's good enough. So fetal movement is very important. They can keep that chart. Now, in cases of FGR with early Doppler changes or a mild associated abnormalities, actually fetal movement count, I should have spoken way earlier than now. Early Doppler changes, mild associated abnormalities like oligohydramnios, suboptimal growth, early PIHUR finding, delivery still you can continue till 37 weeks, definitely. And that till that time, you should use CTG, NST, biophysical profile twice a week, and weekly Doppler studies. In cases of FGR with umbilical artery end diastolic velocity, absent end diastolic velocity, then still you can defer the delivery till 32 weeks. What is important is till you reach to 32 weeks, monitoring is now done in-house. Up till now, I was doing on OPD basis monitoring with the mild or severe FGR when no much Doppler changes were there or early Doppler changes. But now when there is an absence of end diastolic flow, you need to do inpatient monitoring, daily kick count. My patient every day does. We do the CTG and NST. Biophysical profile also we check. And Doppler, you should do alternate day. Doppler with the end diastolic flow absent. In case of a FGR with reversed end diastolic flow, you may still try to pull on till 30 weeks, but again, in-house monitoring, Doppler daily now. It's a reverse end diastolic flow. You should do daily Doppler, daily biophysical profile, daily kick mount. Sometimes if you land up in a trouble, you repent that I would have done her delivery and I would have saved the baby at 30 weeks or 29 weeks rather than trying to pull. Every one of us may undergo such an unfortunate situation. That doesn't mean I should get worried and just deliver unnecessary too early. So don't allow anxiety of an obstetrician to take a decision of delivery. Now, in case of a FGR with abnormal ductus venosus, that is very important. So abnormal ductus venosus, it means now you have to deliver and delivery as early as 26 to 30 weeks. Now, very important when you are doing this at such an early stage, it is important or before 26 weeks, it should be a shared decision between the parents, the couple, the family, the neonatology team, and yourself. You need to sit and tell that, listen, I got now the highest abnormal ductus venosus, Doppler, and I need to deliver her. But these are the chances of survival. What will be the cost of surviving that baby over 6 to 8 weeks also has to be explained. Whether the couple can afford that much is also equally important. And we all know that associated premature retinopathy, the treatment what baby will need for a prevention of a premature retinopathy, all that should be considered, should be spoken. The cost should be explained to the patient, and then saving that baby should not become a burden on a mother, father, or the family. FGR alone, is it an indication for cesarean? Of course not. Primary cesarean should be considered only when there is an absent end diastolic flow or reverse or ductus venosus Doppler changes, or abnormal CTG, flatline, or maternal indication, severe preeclampsia, which there may be. Now, remember one thing. At 34, 35 weeks, you will say that the Bishop's score was not good. But many a times you have to understand the preeclampsia patient, they respond very well with the induction of a labor. So you have to balance with the maturity, with the survival chances, with the maternal condition. But any of these, if it is a mild preeclampsia, 2 percentile growth, but Doppler studies are going well, in anything, you may be thinking about induction of a labor. Now, if you are doing the cesareans, for example, at 30 to 32 weeks of pregnancy, because the fetal Doppler is not showing you, there is no growth happening, and ductus venosus changes have come, what you will do? You have to go for a cesarean, unformed lower uterine segment, vascular lower uterine segment, associated less liquor. There may be a non-vertex position. There may be extensions. So usually what you should do is lower segments, when it is not formed, you should take a U shape. You should go near the angle with the upward direction with the scissors, number one. Number two, try to deliver the baby as early as possible. There may not be enough space. As against the emergency Caesar, which you do at 30 weeks, where the lower segment is formed, it is thin out, and you can just hook out the baby, there may be little difficulty. Don't allow the liquor to be drained out completely. And be prepared for a atony or a PPH in this patient. So what I like to do is simulate the surgery before, whether endoscopy or cesarean. What are the problems I will face? And then accordingly, take adequate incisions also, and mental image of the lie and presentation, very important. Simulate that. Adequate incision you should be taking. Lower segment approach is feasible in most of the cases, but extend the incision with the scissor in upward direction, and in non-vertex position, go for the feet and deliver by IPV, or be quick, or don't let the liquor drain out. And if not, just deliver with that. But be very careful about the aftercoming head. Deliver the head with the fingers rather than the hand, because there may not be enough space because of the rigid lower segment. Forceps is still safe and effective to deliver the head. Delivery of MgR fetuses should ideally take place at the center appropriate to take care of this neonatal care. Please don't allow shifting of the neonate. From you deliver at 30 weeks and then ask the baby, parents to carry on and refer with a chit to the tertiary center to take care of this baby. Remember, in a transit, you may cause a lot of problem for that neonate. And that neonatal hypoxia, if happened during transition, is not good. Better you send the patient for delivering at tertiary center with very good neonatal care unit. Always remember, send this placenta, especially when it is idiopathic. You don't know why this has happened. Everything was normal, but the IUGR was there. Then you should be checking it, histopathological examination. Long-term consequences of the fetus and maternal, very important. Growth-restricted fetuses are at increased risk of short-term and long-term morbidity and should be followed closely, even in grown-up. So once FGR is identified, obstetric management is focused on assuring the safety while the fetus continue to mature within a potentially hostile intrauterine environment. Remember, every word is important. Baby is growing. Baby is trying to mature within a potentially hostile intrauterine environment. But the maturity of the baby counts. The baby weight maybe 1.2 kg has become 1.24 over 4 weeks, over a month. But if the fluid is good, Doppler flow is going well, I will still feel that the maturity is important for me, not necessarily the fetal weight. And neonatologist will always say your everyday maturity, one day also, is very important for them. There is no single test which is superior to other. It is your thinking, your overall thinking about the patient, and decision to deliver, especially below 32 weeks, remains mostly on the basis of empirical management. The trouble with so many of us is that we underestimate the power of simplicity. We tend to mistake movement for achievement. And that's where we do the mistake. Sometimes we don't understand that the baby will grow in this adverse atmosphere better than taking out and making in outside. Baby will go. Sometimes you are surprised that from 28 weeks, you could carry till 33 weeks so easily. And there is definitely a difference in the in the neonatal mortality and morbidity at 28 weeks and 33 weeks, 34 weeks. It's definitely different. So friends, science is not only compatible with spirituality, it is profound source of a spirituality. Tell your mother, keep on talking with the baby. Tell baby to give you a signal when the baby is not well. So when these patients come with the preterm labor of their own, then don't try to give beta mimetics. It is the fetus who is giving a signal that I'm not now anymore comfortable in these adverse circumstances. I'm getting suffocated beyond the limit. And it is the fetus who gives the signal. And then you just maybe till your steroids, you may think about 48 hours, but not beyond that. But at the same time, remember, mother talking to the baby, protecting the baby, and trying to get that baby in this beautiful world is equally important. Friends, I'm going for a Foxy presidential elections. They will happen in first 10 days of September. Every one of you will get a different voting line. Your own link you cannot exchange with the other. My humble request is, I need your blessings. Please bless me and support me. Thank you. I always like to thank my team. They do wonderful job, and they are the reason why sometimes we can run such a high risk obstetric unit. Usually all fellows, they get divided with the different kind of patients, and they take care of this patient to their limit, responding them on their WhatsApp and talking to them, keeping in touch with them is so damn important. And I need to thank each and every fellow and the consultants with me, especially Dr. Samta, who plays such an important role. Thank you so much, friends, for your patient hearing. Thank you. Mr. Bhavik, Vimesh, we are done. You can stop. Thank you, friends.